my name's Chloe and I'm going to be performing a newborn assessment on this new infant. So when I look at the color of this baby, the baby should be pink and there should be no signs of acrocyanosis. So this baby is pink and that's a good sign. This baby should also be lying in a flex position, which this baby is, and when baby moves her extremities, she should move them bilaterally and symmetrically, which she does. So that's a good sign for a newborn baby, and we like to see that. Okay, so looking at baby's head, we're going to assess the fontanelles. We're going to assess that there's an anterior fontanelle that's diamond shaped, and we're going to assess that there's a posterior fontanelle that is triangular in shape. And if we see a sunken fontanelle, that's indicative of dehydration, which we want to report to the provider. And if we see a bulging fontanelle, that's indicative of increased intracranial pressure, which we want to report that to the provider immediately. So looking at suture lines of the baby's head, we just want to make sure that they're well approximated and that they do not overlap each other. And also some abnormalities that you might see in a baby's scalp are cephalohematoma, which is just bleeding beneath the periosteum that does not cross the suture lines. And then you might also see a caput succedaneum, which is just swelling at the crown of baby from the pressure and the trauma of the birth canal, which that will go away within 1 to 3 days. And in measuring the baby's head circumference, we're just going to lift the baby's head off the bed just slightly, and we're going to measure right here at the frontal lobe to the back of the occiput, and we want to make sure that's 32 to 38 centimeters, which is a normal finding for a newborn baby. Also, we want to make sure that the head of the baby is 1/4 of the length of the rest of its body, which it is, so that's a normal finding for a newborn baby. So looking at baby's face, we just want to make sure that it's symmetrical. We want to look at the face, mouth, and nose, make sure they're symmetrical because we don't want to see that there's a facial nerve injury. So looking at baby's eyes, we want to note the color first off. So this baby's eyes are green, and then we're going to assess for perla. Measure the size. So this baby's eyes are perla and 4 millimeters, which means that these pupils are equal, round, and reactive to light and accommodation. And like I said, they are bright green eyes. So now I'm going to look at the baby's ears. I want to make sure that the top of the baby's pinna aligns with the outer canthus of their eyes. And if it's lower or higher, we want to report that. And if you see a periauricular skin tag on this baby's ear, that's associated with renal malformation, which we want to report that to the provider immediately. Okay. So now that we're on the baby's face, I just want to look at their mouth. I want to look for Epstein pearls in the mouth, which are just little pustules that will go away with time, and they are normal in newborn babies. And I also want to look for circummoral cyanosis around the baby's mouth, and that's just a bluing, and that's because of decreased oxygenation in the baby's mouth. And if we see that this increases with crying or increases with activity and then decreases once the crying stops, there might be some cardiovascular issues that need to be addressed. But if the longer the baby cries, the less circummoral cyanosis we see, that's a good sign because that means that baby's getting a little bit more oxygen. So we like to see that. And along with looking at the baby's mouth right here, I want to assess for the rooting reflex. So I'm just going to place my finger, my gloved finger, or you can do this with a pacifier, along the baby's cheek, and I'm going to pull a little bit. And the baby should turn towards the passy or gloved finger, which she does. So that's a normal finding for a newborn baby. And I also want to assess for nostril patency. This is good because babies are nose breathers, so we just want to make sure they can get air in and out. So I'm going to assess this by placing one finger over one nostril. And what I want to see is that air comes out of the other nostril. And I'm going to do this on both sides because we want to assess bilaterally. All right, that's good. Okay, so after we're finished with the eyes, nose, mouth, and ears and the rooting reflex, I'm going to assess the baby's neck. I want to see that the neck folds on the babies are short and thick. And I want to assess that they are easily movable and they're not stiff. And I want to also look for webbing or an obvious fat pad because that's not a good sign and we want to report that to the provider immediately. So we're just going to look and make sure that they're super symmetrical, which they are. And now that I've assessed the baby's neck, I want to assess the clavicles for fractures. The way that we do this is we just palpate them. And if we feel a palpable lump on the baby's clavicle, or if the baby's in obvious pain, or if you can feel the fracture, then there is probably a fracture and we are going to report that to the healthcare provider immediately. So now assessing baby's chest, I want to measure the baby's chest and I want to measure around the nipple line and I want it to be 30 to 36 centimeters in circumference. So the nipples of baby might be a little bit swollen from maternal hormones, but that will go away with time. And I'm just going to measure 30 to 36 centimeters. And we want the baby's chest to be cylindrical in shape, and that's a normal finding for a newborn baby. Okay? And so now moving down to baby's belly, I just want to ensure that it's soft and round and it's not firm to palpation. But I'm not going to palpate before I listen. I'm going to listen first. And before I listen, I just want to talk about the umbilical cord. When I see this umbilical cord, I just want to make sure that it's a blue-white color and that we just ensure paresis will darken over time. We're also looking for 2 arteries and 1 vein. And you may not see these very distinctly, but that is a normal finding. And finally, if you see a bulging of the umbilicus, that is indicative of an umbilical hernia, which we would want to report to the provider immediately. So now I'm going to listen to baby's belly. And bowel sounds might not be active in the first few hours of birth because all baby has taken into their gut is amniotic fluid and no other fluid or feedings. But once they start the feeding pattern and the regularity of that, then we'll hear bowel sounds. And now that I'm listening, I'm just going to listen to the baby's heart rate too. So we want the heart rate of the baby to be between 120 and 160 beats per minute. And this might be irregular just because babies aren't used to having their own circulation. They've been on fetal circulation, so this might be a little irregular. And we want to listen with the pediatric side of our stethoscope so we don't hear any bowel sounds along with heart sounds. And like I said, we are going to listen for 1 full minute, and a normal rate is 120 to 160. So I'm not going to listen for 1 full minute because this is just an exercise, but in the clinical setting, we would listen for 1 full minute. So after palpating baby's apical pulse, I'm going to feel for the brachial pulses. I'm going to palpate those, and we should do this bilaterally and symmetrically. So these are 2+ brachial pulses bilaterally. And I'm also going to feel for femoral pulses, and these are between the groin. And these are also 2+ bilaterally, so that's a good sign. So after assessing the baby's cardiovascular status, I just want to talk about blood pressure for a second. You wouldn't routinely check a baby's blood pressure because it's just not necessary at this stage in their life. But if you did have to check it for any reason, a normal systolic blood pressure is 65 to 95, and a normal diastolic blood pressure in an infant is 30 to 60. So those are just normal, but like I said, you don't usually have to check them. So now, moving to baby's respirations. A normal respiratory rate in an infant is 30 to 60 beats per minute. And when we're feeling this, we're going to place our hand over the abdomen and chest right here, and we're just going to feel for 1 full minute. The reason we feel for 1 full minute is because infants have irregular breathing patterns with short periods of apnea sometimes because they are not used to breathing on their own. And this will become more regular with time. And babies who are delivered via cesarean delivery may have more fluid in their lungs because vaginal delivery babies go through the birth canal, and when they go through, their lungs are pressed in, so the fluid actually escapes their lungs more and they can breathe more clearly. So cesarean delivery babies may have more trouble breathing. So before I assess the respiratory rate, I just want to talk about the signs of respiratory distress just in case your cesarean delivery or vaginal delivery baby goes into these. So the signs of this are intercostal retractions, circummoral cyanosis, asymmetrical expansion of the chest, rapid respirations, nasal flaring, and grunting. So now that we know that, I'm going to feel for a respiratory rate for 1 full minute, and we want it to be between 30 and 60 breaths per minute. And again, I'm not going to feel for 1 full minute because this is an exercise, but if I was doing this in the clinical setting, I would feel for a full minute. So now I'm going to move to some reflexes that I want to complete. The first reflex I want to complete is the Moro reflex. What I'm going to do is I'm going to lift baby slightly off the bed, and I'm going to drop her down. Whenever I drop her down, a positive Moro reflex is indicative of the baby creating C-shaped hands and abducting her arms. She might lean her head back a little and startle a little bit. But after that initial startle, she should bring back her arms and adduct them back into her body. So I'm going to complete the Moro reflex. And her hands go into a fanned C-shaped position, her arms abduct, and then they pop back into place. So that's a positive Moro reflex. So now I'm going to assess for the Palmer reflex. So what I'm going to do is place my finger in the baby's palm, and she should grasp my hands. That's a positive Palmer reflex. And then when I'm looking at the baby's palms, I want to look for a semi-increase. If I see a semi-increase, that is indicative of a genetic deficiency, which we would report to the provider immediately. And we want to do this symmetrically and bilaterally, like I said. So now moving down to the legs, I'm going to assess for hip dysplasia. The way I'm going to do this is by using Ortolani's sign. So I am going to rotate baby's legs. I'm going to rotate them together in a circular motion. And I'm going to listen for a positive Ortolani click. What this means is that if there is hip dysplasia present, that baby, the baby's femoral head will slip out of the acetabulum, which is their hip joint, and the hip socket, and so that would be it. Then you would hear the click. But I don't hear the click, so we're not going to go on with that intervention. Okay, so I'm going to also assess for a plantar grasp. I'm going to do the same thing as the palmar grasp, but I'm going to do it on baby's feet. I'm just going to put my fingers right here, and baby will grasp me with her feet, and she does. And finally, I'm going to assess for the Babinski's reflex. So I'm going to brush my finger from the bottom of her foot to the top of her foot, and her fingers should fan out. And I'm going to do this bilaterally. And they do. So that is a good finding. And now that I'm at the baby's feet, I'm just going to assess for any polydactyly, which would mean like several or extra fingers or toes, or webbing where the fingers or the toes are connected. And I'm also going to assess for club feet. So I'm just going to look at all of that, which I see none of that. So that's a good finding, and we are good with that. So now what I'm going to do is I'm going to turn this baby over, and I'm going to assess her back. When I stand baby up, I'm going to assess the stepping reflex and ensure that whenever I hold baby off the ground, she steps a little, and she does. So now I'm going to look at the baby's back, and I want to see a straight, flat spine, and I see that. And also looking at the sacrum of the baby, I want to assess for a sacral tuft of hair. That's indicative of spina bifida and needs to be reported to the healthcare provider. If you see a sacral dimple, that is indicative of a pylondrial cyst or a sinus, which also needs to be reported to the healthcare provider. You may also see a Mongolian spot, which is just a darkened area on the baby's buttocks, and that is normal, and it might go away with time and it might not. And these are most common in African American and Hispanic infants. So looking at the buttocks of the baby, I just want to ensure that the creases in the baby's buttocks are symmetrical and that they are just lined up with each other perfectly. And then I also want to ensure that the baby's legs are of the same length from the hip to the bottom of the feet, and they are, which is a good sign for a newborn baby. Okay. So now looking at baby's anus, I just want to assess for fissures. I want to assess just by visualizing, and I see no fissures present. And finally, I'm going to look at the genitalia of the baby. So looking at the baby, initially you may see some edematous labia, which is normal from the birthing process. And then you may also see some vaginal discharge or bleeding from the maternal hormones that also cause the nipple swelling. So that's normal and will go away with time. And you may also see some vernix present in the folds of the newborn's genitalia, which is normal and will go away with time. Okay. Let's see. And after assessing genitalia and the anus for fissures, my newborn assessment is complete. I'll put a new dry diaper on the baby and send her back to mom.